Lower esophageal, gastric and duodenal ulcer. Peptic ulcer. Introduction. Lower esophageal, gastric and duodenal ulcers are types of peptic ulcer. The main distinction is that they affect different parts of the digestive tract. A person could have all at the same time. Peptic ulcers include lower esophageal ulcer that on the lower part of esophagus, gastric ulcers that occur on the inside of the stomach, duodenal ulcers that occur on the inside of the upper portion of small intestine, duodenum. Definition. Lower esophageal, gastric and duodenal ulcers are peptic ulcers, which are open sores in the lining of the digestive tract. A peptic ulcer is a sore on the lining of stomach or the first part of small intestine, duodenum. If the ulcer is in stomach, it is called a gastric ulcer. If the ulcer is in duodenum, it is called a duodenal ulcer. A peptic ulcer is an excavation that forms in the mucosal wall of the stomach, in the pylorus, in the duodenum, or in the esophagus. A peptic ulcer is a break in the lining of the gastrointestinal tract, extending through to the muscular layer, muscularis mucosae, of the bowel wall. Statistics and epidemiology. Peptic ulcer disease may occur in both genders and in all ages. Peptic ulcer disease occurs with the greatest frequency in people between 40 and 60 years of age. It is relatively uncommon in women of childbearing age, but it has been observed in children and even in infants. After menopause, the incidence of peptic ulcers in women is almost equal to that in men. Classification. Peptic ulcer is classified into gastric, duodenal or esophageal ulcer. Gastric ulcer. Gastric ulcer tend to occur in the lesser curvature of the stomach, near the pylorus. Duodenal ulcer. Peptic ulcers are more likely to occur in the duodenum than in the stomach. Esophageal ulcer. Esophageal ulcer occur as a result of the backward flow of HCl from the stomach into the esophagus. Causes. There are three major causes of peptic ulcer disease: infection with H. pylori, chronic use of NSAIDs, and pathologic hypersecretory disorders, e.g., Zollinger-Ellison syndrome. Helicobacter pylori. Research has documented that peptic ulcers result from infection with the gram-negative bacteria H. pylori, which may be acquired through ingestion of food and water. H. pylori damages the mucus coating that protects the stomach and duodenum. Salicylates and NSAIDs. Encourages ulcer formation by inhibiting the secretion of prostaglandins. Various illnesses. Pancreatitis, hepatic disease, Crohn's disease, gastritis, and Zollinger-Ellison syndrome are also known causes. Excessive secretion of HCl in the stomach may contribute to the formation of peptic ulcers. Irritants. Ingestion of milk and caffeinated beverages and alcohol also increase HCl secretion. These contribute by accelerating gastric emptying time and promoting mucosal breakdown. Blood type. Gastric ulcers tend to strike people with type O blood, while duodenal ulcers tend to afflict people with type O blood. Pathophysiology. Clinical manifestations. Symptoms of ulcer may last for a few days, weeks, months, and may disappear only to reappear, often without an identifiable cause. Pain. As a rule, the patient with an ulcer complains of dull, gnawing pain or a burning sensation in the mid-epigastrium or the back that is relieved by eating. Pyrosis. Pyrosis, heartburn, is a burning sensation in the stomach and esophagus that moves up to the mouth. Vomiting. Vomiting results from obstruction of the pyloric orifice, caused by either muscular spasm of the pylorus or mechanical obstruction from scarring. Constipation and diarrhea. Constipation or diarrhea may occur, probably as a result of diet and medications. Bleeding. 15% of patients may present with GI bleeding as evidenced by the passage of melena, tarry stools. Assessment and diagnostic findings. To establish the diagnosis of peptic ulcer, the following assessment and laboratory studies should be performed. History taking. Physical examination. A physical examination may reveal pain, epigastric tenderness, or abdominal distension. Esophagogastroduodenoscopy confirms the presence of an ulcer and allows cytologic studies and biopsy to rule out H. pylori or cancer. Barium study. A barium study of the upper GI tract may show an ulcer. Endoscopy. Endoscopy is the preferred diagnostic procedure because it allows direct visualization of inflammatory changes, ulcers, and lesions. Occult blood. Stools may be tested periodically until they are negative for occult blood. Carbon-13, 13C, urea breath test. Reflects activity of H. pylori. Medical management. Treatment can include making lifestyle changes, taking medicines, or in some cases having surgery. Lifestyle changes may include not eating certain foods. Avoid any foods that make symptoms worse. Quitting smoking. Smoking can keep the ulcer from healing. It is also linked to ulcers coming back after treatment. Limiting alcohol and caffeine. They can make symptoms worse. Not using NSAIDs, non-steroidal anti-inflammatory medicines. These include aspirin and ibuprofen. Medicines to treat ulcers may include antibiotics. These bacteria-fighting medicines are used to kill the H. pylori bacteria. Often a mix of antibiotics and other medicines is used to cure the ulcer and get rid of the infection. E.g. ceftriaxone, amoxicillin, amikacin. H2 blockers, histamine receptor blockers. These reduce the amount of acid client stomach makes by blocking the hormone histamine. Histamine helps to make acid. E.g. Aciloc, Zintec, ranitidine, famotidine. Proton pump inhibitors or PPIs. These lower stomach acid levels and protect the lining of stomach and duodenum. E.g. pantoprazole, omeprazole. Mucosal protective agents. These medicines protect the stomach's mucus lining from acid damage so that it can heal. Antacids. These quickly weaken or neutralize stomach acid to ease your symptoms. Surgical management. Partial gastrectomy. In order to control acid levels, doctors take out part of the stomach that stimulates acid release to keep acid levels down. Vagotomy. In this procedure, the surgeon selectively cuts the vagus nerves or its smaller branches, which stimulate acid production. Pyloroplasty. According to McGuigan, vagotomy was once often performed in combination with the pyloroplasty, surgery that widens the base of the stomach. This procedure, as well as others, can be done for obstructed gastric emptying due to ulcer scarring or inflammation. Billroth I, more formally Billroth's operation I, is an operation in which the pylorus is removed and the distal stomach is anastomosed directly to the duodenum. Billroth II, more formally Billroth's operation II, is an operation in which a partial gastrectomy, removal of the stomach, is performed and the cut end of the stomach is closed. The greater curvature of the stomach is then connected to the first part of the jejunum in N2-side anastomosis. The Billroth II always follows resection of the lower part of the stomach, antrum. The surgical procedure is called a partial gastrectomy and gastroduodenoscopy. The Billroth II is often indicated in refractory peptic ulcer disease and gastric adenocarcinoma. Nursing management. The management of the patient with peptic ulcer is as follows. Nursing assessment. Assessment for description of pain. Assessment of relief measures to relieve the pain. Assessment of the characteristics of the vomitus. Assessment of the patient's usual food intake and food habits. Nursing diagnosis. Acute pain related to the effect of gastric acid secretion on damaged tissue. Anxiety related to an acute illness. Imbalanced nutrition related to changes in the diet. Deficient knowledge about prevention of symptoms and management of the condition. Nursing care planning and goals. The goals for the patient may include relief of pain, reduced anxiety, maintenance of nutritional requirements, knowledge about the management and prevention of ulcer recurrence, absence of complications, nursing interventions, relieving pain and improving nutrition, Administer prescribed medications. Avoid aspirin, which is an anticoagulant, and foods and beverages that contain acid-enhancing caffeine, colas, tea, coffee, chocolate, along with decaffeinated coffee. Encourage patient to eat regularly spaced meals in a relaxed atmosphere, obtain regular weights and encourage dietary modifications. Encourage relaxation techniques. Reducing anxiety. Assess what patient wants to know about the disease, and evaluate level of anxiety. Encourage patient to express fears openly and without criticism. Explain diagnostic tests and administering medications on schedule. Interact in a relaxing manner, help in identifying stressors, and explain effective coping techniques and relaxation methods. Encourage family to participate in care, and give emotional support. Monitoring and managing complications. If hemorrhage is a concern, assess for faintness or dizziness and nausea, before or with bleeding, test stool for occult or gross blood, monitor vital signs frequently, tachycardia, hypotension, and tachypnea. Insert an indwelling urinary catheter and monitor intake and output. Insert and maintain an 4-line for infusing fluid and blood. Monitor laboratory values, hemoglobin and hematocrit. Insert and maintain a nasogastric tube and monitor drainage. Provide lavage as ordered. Monitor oxygen saturation and administering oxygen therapy. Place the patient in the recumbent position with the legs elevated to prevent hypotension, or place the patient on the left side to prevent aspiration from vomiting. Treat hypovolemic shock as indicated. If perforation and penetration are concerns, note and report symptoms of penetration, back and epigastric pain not relieved by medications that were effective in the past. Note and report symptoms of perforation, sudden abdominal pain, referred pain to shoulders, vomiting and collapse, extremely tender and rigid abdomen, hypotension and tachycardia, or other signs of shock. Home management and teaching self-care. Assist the patient in understanding the condition and factors that help or aggravate it. Teach patient about prescribed medications, including name, dosage, frequency, and possible side effects. Also identify medications such as aspirin that patient should avoid. Instruct patient about particular foods that will upset the gastric mucosa, such as coffee, tea, colas, and alcohol, which have acid-producing potential. Encourage patient to eat regular meals in a relaxed setting and to avoid overeating. Explain that smoking may interfere with ulcer healing. Refer patient to programs to assist with smoking cessation. Alert patient to signs and symptoms of complications to be reported. These complications include hemorrhage, cool skin, confusion, increased heart rate, labored breathing, and blood in the stool, penetration and perforation, severe abdominal pain, rigid and tender abdomen, vomiting, elevated temperature, and increased heart rate, and pyloric obstruction, nausea, vomiting, distended abdomen, and abdominal pain. To identify obstruction, insert and monitor nasogastric tube. More than 400 ml residual suggests obstruction. Evaluation. Relief of pain. Reduced anxiety. Maintained nutritional requirements. Knowledge about the management and prevention of ulcer recurrence. Absence of complications. Complications. Cause. Bleeding. Ulcer wears away the stomach or small intestine and breaks the blood vessels there. Perforation. Ulcer breaks through the lining and stomach wall, causing bacteria, acid, and food to leak through. Peritonitis. Inflammation and infection of the abdominal cavity due to perforation. Blockage. Scar tissue can form as a result of the ulcers and keep food from leaving the stomach or duodenum.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.